السلام عليكم دكتورة أسماء.
السلام عليكم ورحمة الله وبركاته.
عليكم السلام. Dr. Asma Al Shidhani is a consultant family physician in Sultan Qaboos University Hospital. She is the president of Oman Family Medicine Society and the chairperson of examination committee in the residency program. She is known for her special interest in education and research. She is not only a published author, but also a reviewer in many medical journals. We are very honored to have you with us, Dr. Asma. Please, the mic is yours.
Okay, thank you very much, Dr. Amina, for this introduction. Inshallah ta'ala, I will start my presentation. I tried my best to cover most of the topics in dermatology in primary care, but dermatology topics are very broad and very common in primary care. 1 hour is not enough for to cover all the topics. So, inshallah ta'ala, we'll enjoy together this presentation. Do you see the slide?
Yes, Doctora, proceed.
Is it in presentation mode now?
Yes.
Okay, Bismillah. Bismillah ar-Rahman ar-Rahim. So, I will talk about common dermatological conditions in primary care. The outline is I will talk about skin rashes, fungal infections, dermatitis, acne, rosacea, psoriasis, and shingles. As I told you before, it's not the only ones. It's hundreds of dermatological problems we are seeing in primary care, but I tried to select the common ones. When you are seeing any skin rash, very important to know that, to see that, or to look at the appearance of the rash. What does it look like? The location of the rash, the clinical course, and what are the associated symptoms. Sorry, 1 minute. I need to remove this one. Okay. Okay. So, appearance of the rash. What type of rash? Is it maculopapular? Is it vesicles, or is it plaques? Then the location of the rash, you should see from where it started and where is the distribution. Is it flexor surfaces, or is it in the extensor surfaces? Is it in the trunk or face? The clinical course, how it is started, and when it reached, is it started from the face, then spread to the body, or the opposite? Does it spare any part of the body? How many days since started? Then after how many days it faded? The associated symptoms, like common ones like fever, pruritus, and other symptoms. So if we're thinking of history and physical examination when we are seeing a skin rash, it's very important, as we said before, to see the duration of the rash, when it started, any initial appearance and progression, location of the rash, any history of contact, especially most of the rashes are infectious causes. Any history of use of medications, environmental exposures, like in dermatitis and irritants, and like drug-induced eruptions, and any other symptoms like fever and pruritus. Then the physical examination, very important to decide and to look to decide what type of lesions you are seeing, and where is the location and how it's distributed, how is the arrangement comes, shape of the lesions, color, and is it associated with scale or not? Now, this is the first case. I would like to make the presentation more interactive, so please, anyone want to answer, please answer. A 12-month-old infant with no past medical problems present to the clinic with his mother. According to the mother, the child developed a high fever, 40 degrees, 4 days back. On the 3rd day, the patient's fever resolved, and he began to exhibit diffuse rash. The eruption started in the patient's chest, moved peripherally to the abdomen, upper extremities, neck, and face. No other symptoms apart from mild rhinorrhea and non-productive cough. So, describe the rash. What is the most likely diagnosis and how to treat? First, we'll start with describing the rash. Anybody want to describe the rash? Okay, so I'll proceed. This is mainly a maculopapular rash.
Asma, you can see the answers in the chat.
Okay, sorry. Yes. Yeah, it's maculopapular rash, widespread macular and the trunk. So what is the most likely diagnosis? Erythema, yeah. Not multiform. It started with erythema. Okay, roseola, rubella. Okay, thank you for the answers. We'll see what is it. It is, yeah, Roseola infantum or exanthema sabitum. Roseola is most commonly caused by human herpes virus 6. It affects infants and children younger than 3 years. It is characterized by abrupt onset of high fever lasting 1 to 5 days. Maybe Dr. Amina make next time gift for the answers. It's characterized by abrupt onset of high fever lasting 1 to 5 days. During this period, children often appear well with no focal clinical signs except possible mild cough, rhinorrhea, mild diarrhea, which is the common ARI symptoms. And after resolution of the fever, the dermatitis maculo to maculopapular rash start, which appears in the start from the trunk, then spread peripherally. Roseola is a self-limited illness requiring no treatment and diagnosis usually clinical. But when we are asking ourselves, roseola, what does it look like? What other diseases almost appear with the same like roseola? Any suggestion? Measles, excellent. So we have a motion character. Measles looks like, roseola infantum looks like measles, but the differences are mainly two. The rash progression, usually roseola rash begins in the trunk and spread out, while the measles rash starts on the face and moves downwards. So very important to take the history of progression of the rash. The second important thing that usually kids with roseola present, they are well appearing. When there is no fever period, they are well, but the kids with measles usually appear unwell. The second case is 10-year-old boy present with skin rash on the trunk for 2 weeks. The rash is associated with mild itching. There is no history of contact with similar rash. He has no fever and examination as below. Again, describe the rash. I see the answers. So, Herald, yes, excellent. Okay, Pityriasis rosea, excellent. So, how you will manage Pityriasis rosea? Self-limiting, excellent. Okay. So Pityriasis rosea present with a single oval-shaped rose-colored patch, which we call it Herald patch. Usually on the trunk, 80% of cases present with Herald patch. It may present for a few weeks before the development of smaller lesions that are similar to the primary patch. And usually it maintains a classical appearance, which they call Christmas tree appearance, where it goes with the lines of longer lines in the body. Children with Pityriasis rosea may have history of mild upper respiratory tract infection symptoms, and up to 1/2 have pruritus with a rash. The rash associated with Pityriasis rosea may present 2 to 12 weeks. It is, as you said, it's self-limiting. Although the etiology is not known, but there are theories saying that maybe it's related to human herpes virus 6 and 7. What does it look like? It looks like Tinea corporis. The difference are the Pityriasis rosea most commonly occur in the chest or the back, while the ringworm can occur anywhere in the body, including scalp, fingernails, face, or legs. Also, in case there is, for example, they are not sure about the diagnosis, maybe you can use potassium hydroxide preparation to distinguish between the fungal and non-fungal infection. This is the third case. An 8-year-old girl was brought by her mother with history of sore throat 2 days ago. She started to notice a pain on swallowing and had a temperature of 38. Her mother decided a skin rash. Her mother noticed a skin rash on the girl trunk and the inside of her elbows. Her anterior cervical nerves are swollen and tender. So, what is the most likely diagnosis? Scarlet, excellent. How describe the rash? Sandy, okay. Sandy, okay. Okay. Sandpaper-like rash. Okay. Thank you. So scarlet fever present in 10% of children with streptococcal tonsillophlebitis. Usually the incubation period about 1 to 4 days. Fever and sore throat 1 to 2 days before the rash. Then the rash will come, which is very unique for scarlet fever, where it's usually erythematous sandpaper rash, confluent maculopapular. It lasts about 6 to 9 days. And there are petechiae on the soft palate, circumoral failure, desquamation or peeling off on the face start, then it will spread to the rest of the body, which may last 4 to 6 weeks. And the important one is the strawberry tongue. How you manage scarlet fever? Usually, scarlet fever it's caused by group A streptococcal infection. So throat culture is advisable, but because of it's not practical to wait for the throat culture. There is rapid antigen test with high sensitivity of 86. Usually the culture above 90, 92 to 94% sensitivity, and the rapid antigen test is 86, so almost close to each other. Cultures may be ordered when the suspicious group A streptococcal infection is high, despite the rapid antigen test is negative. So how to treat? We treat with antibiotic. Usually penicillin is the therapy of choice for streptococcal infection, but those people with allergy who are having allergy to penicillin or cephalosporins maybe can be treated with oral macrolides like erythromycin, azithro, and clindamycin. Next case is a 7-year-old boy present with a 3-day history of sores on his chin. The sores began as a small red papules but have progressed in size and now are crusting and weakening. So again, describe the rash. Impetigo, excellent. How to treat impetigo? Okay, honey crust rash, yes, excellent. How to treat it? Topical antibiotics, yes, excellent. So impetigo is a primary or secondary bacterial infection of the epidermis of the skin. There are 2 types. We have bullous and non-bullous. The bullous form, usually it comes in the neonates, but the non-bullous one is the most commonly seen, which is at preschool and school-age children. Streptococcal pyogenes causing the non-bullous one, the common one, and Staph aureus is causing the bullous one. The rash initially the patient develops vesicles or pustules that form a thick yellow crust. With auto-inoculation, the lesions may quickly spread. Usually, the face and extremities are the common site affected. Impetigo, usually it is a self-limited disease, but because of the risk of complication and risk of spread to other parts of the body, usually treated with antibiotic, and usually it's a topical antibiotic, and for the non-bullous one. But when we can use systemic antibiotics, there are many indications for systematic antibiotic use, like if there is non-bullous impetigo with non-bullous with extensive involvement, like an athletic team to avoid spread of the infection, child care clusters also to avoid spread of the infection, multiple family members, the same reason, and bullous impetigo in the neonates. Then we have a 7-year-old girl brought by her mother with history of fever and headache. 3 days later, she developed bright red cheeks, and today she started to have skin rash that appears on the arms, legs, trunk, and buttocks. Again, what is the diagnosis and describe the rash? Erythema multiforme, slap cheek syndrome, yes, slap cheek, okay. 5th disease, excellent. So describe the rash. Try with the ones in the front. We call it lacy rash, maybe you can say it. Okay, erythema infectiosum, 5th disease. Erythema infectiosum is caused by parvovirus B19. It's a common childhood infection. The incubation period 5 to 21 days after exposure. What are the characteristics of the rash? It starts with prodrome of low-grade fever, malaise, sore throat, headache, and nausea, like common viral infections. followed several days later by erythematous slabbed cheek, which is in the face. And after 2 to 4 days, the facial rash fades. Then the pink patches and macules may develop in a lacy reticular pattern, most often on the extremities. After 1 to 6 weeks, the rash resolves, but may reappear with sun exposure, heat, or stress. If you have any questions, please tell me. In erythema infectiosum, arthralgias occur in approximately 8% of young children with the disease, but are much more common in teens and young adults. Should an infected person, this is for patient advice, should an infected person be excluded from school, daycare, or work? No, as long as the person is feeling well enough to participate in normal activities, patients are no longer considered infectious once the body rash appears and fever subsides. So once the fever subsides and the rash started to appear, the child can go to school or any activities. Treatment is symptomatic like any virus and includes nonsteroidal for arthralgias and antihistamines for pruritus. Then, a 7-year-old boy present with multiple. Any questions? Okay. How can we differentiate between scarlet fever and Kawasaki disease? Actually, Kawasaki disease, usually the fever is lasting more, not less than 5 days, very high fever, plus there are cervical lymph nodes and the skin rash and skin peeling of the extremities. Okay, we'll start the case. A 7-year-old boy present with multiple small painless lesions on his face for the last 1 month. Can you describe the rash? Yes, excellent. Okay, Molluscum contagiosum. Okay, excellent. How to treat Molluscum contagiosum? Okay, with a dome. Okay, cryotherapy. Excellent. Conservative. Complicated. Okay, thank you very much. Okay, Molluscum contagiosum is highly contagious viral infection caused by pox virus. Most commonly affects children 2 to 11 years of age and in sexually active adolescents. The lesions are flesh-colored or pearly white, small papules with central umbilication. The oral mucosa is rarely affected, but lesions may appear in genital area, and so it can be in the face or genital area and conjunctiva. Typically, usually children, as we said, 10 to 20, they have 10 to 20 lesions, but maybe hundreds of lesions there. It can abrupt and spread quickly in children with underlying atopic dermatitis. We call it molluscum dermatitis. So, diagnosis is easy and usually made clinically. The condition, as you said, it's self-limited and may last for months or sometimes even years. Treatment options usually only if there is a physical appearance concern. Otherwise, no need for treatment. As you said, it's self-limited. They use different modalities like cryotherapy and intralesional immunotherapy. Dermatitis occurs, molluscum dermatitis or flare-up of atopic dermatitis requires treatment to resolve pruritus and limit spread of the molluscum. So they're using this modalities of treatment. There is that's okay. A 25-year-old woman present with history of red scaly patches on her arm for the last 10 days. So what is the diagnosis? Ringworm, excellent. Tinea corporis. Okay, excellent. How to treat tinea? Antifungal. What type of topical antifungal? Excellent. So we'll talk about tinea infection, but depends on the site of the body it's called, like tinea capitis in the scalp, tinea corporis in the body, which is ringworm, tinea versicolor because 2 different colors, tinea cruris in the groin, tinea pedis in the feet, tinea manus in the hands, and then onychomycosis. We'll start with tinea capitis. It most commonly affects children. Early disease, itching and scaling may start with, and then classic presentation, which is 1 or more of scaling, alopecia, and adenopathy. It may progress to carrion, and which is buggy, tender, plagues, and pustules. This is the picture down is the carrion, and this is the usual presentation of tinea capitis. Diagnosis mainly it's clinical. Only in atypical cases or cases not responding to treatment, we need to go for KOH or culture. How to treat? Systematic antifungal as topical agent do not penetrate the hair shaft. So we need to use systematic antifungal because the topical agent doesn't penetrate the hair shaft. Plus the systemic antifungal, we should use 1% or 2.5% selenium sulfide shampoo or 2% ketoconazole shampoo for the first 2 weeks to reduce transmission. Then options of systematic antifungals, many options we have with systemic systemic antifungal infections with the same almost effectiveness. The advice the child can return to school once treatment started, and for 14 days, the child shouldn't share personal things like combs, brushes, helmets, and hats or pillowcases, or participate in a sports that involve head-to-head contact to avoid transmission of the disease. Then, tinea corporis, it most commonly affected children, typically present as red annular scaly pruritus. You see the scale in the lesion patch and with central clearing and active borders. You see that these borders are active and a bit elevated than the central area. Diagnosis, same like tinea capitis. It's a clinical, and only in atypical cases or cases resistant to treatment, we need to go for using KOH. How to treat? Topical antifungal for 2 to 4 weeks. Usually we have good options of topical antifungal, or antifungal agent may be indicated if extensive disease, failed topical treatment, or in case of immunocompromised patients. What advice we should give to the child? The child can return to school once treatment started and shouldn't share clothes or participate in sports that involve body contact like boxing. Then we have tinea versicolor, or we call it Pityriasis versicolor. It is superficial fungal skin infection caused by Molluscum species. Presentation, how it presents. Usually it presents as hypopigmented plaques, but sometimes it comes as hyperpigmented. I think it's related to the skin color with fine scales. Common site, usually neck, cheek, chest, back, abdomen, and proximal extremities. The diagnosis is mainly clinical. In atypical cases, we need to confirm that it's fungal. I'm checking the chat. Okay. Then for tinea versicolor, how to treat? Usually we treat with topical treatment for at least 2 weeks. We have also different options like clotrimazole, miconazole, selenium sulfide, and terbinafine. Oral antifungal treatment may be used if topical treatment is successful or impractical. And sometimes we are using lotions and soap because using the creams is not practical if it is very extensive area. Then we come to tinea cruris, or jock itch, they call it, in the groin. It's commonly affects adolescents and young adult males. It involves the portion of the upper thigh opposite the scrotum. Usually the scrotum is spared. Classic presentation, there is erythematous, sorry, maybe the picture is, it's okay, I'll change it before sending it to you. Classic presentation for erythematous, scaly, sharply demarcated pruritic rash in the groin, possibly with central clearing and scaling. Diagnosis, same like what said before, it is clinical. Only in atypical cases or not responding cases we do KOH or culture. How to treat? Usually topical antifungal is enough for 2 to 4 weeks. The options of topical agent, terbinafine, butyrenafine, or azoles. Oral antifungal agent may be spared only for extensive disease or failed topical treatment or immunocompromised patient. What advice we can give our patient? To wear loose-fitting, non-restrictive garments and clothing to avoid humidity, extra humidity in that area. Tinea pedis, or we call it also athlete's foot. It most commonly affects people who have sweaty feet while wearing tight fitting shoes, and also we are seeing it commonly in our diabetic patients. It involves the skin between the toes, but can spread to the sole, sides, and dorsum of the foot. It presents with erythema, maceration between the toes, sometimes accompanied by painful vesicles. The chronic form is associated with scaling, peeling, erythema between the toes. How diagnose? It's clinical again. Only atypical cases, KOH and culture can be used. Now, the topical, the treatment is mainly topical for 2 to 4 weeks. Option all the topical antifungal or an antifungal agent may be spared only to extensive disease, failed topical treatment, or immunocompromised. If you will see that most of the things are repeated, but it's just the names different and the site and maybe the management sometimes systematic and the topical. The advice: wear white shoes, dry between the toes after bathing, and place lamps fall between toes. Tinea manus usually affects the hands. It's the palmar surface is diffusely dry and hyperkeratotic. If the fingernails are involved, vesicles and scant scaling may present. It occurs in patients with tinea pedis, and usually if the patient is still having tinea pedis or onychomycosis, even if you treated tinea manus, still will recur again and will relapse. So you need to treat all the types of fungal infection at the same time. Diagnosis: clinical, and only atypical cases you will go for culture or KOH. The management: topical antifungal, usually it's more than enough. Application: if emollients containing lactic acid will help to resolve the problem faster. Onychomycosis, which is a common problem we see in primary care. It's characterized by thickened, brittle, discolored nails. The diagnosis usually confirmed with KOH or culture or past stain, because the treatment is needed because it needs a long treatment, and usually it can be mixed with chronic trauma and psoriasis. Involvement of multiple toenails or presence of tinea pedis may justify treatment without confirming the diagnosis. So, how can we treat? We treat it with oral therapy. Oral therapy is the most effective treatment for onychomycosis for any severity. It has a higher cure rates and shorter treatment periods than topical therapy. When we have the terbinafine is the first choice, then itraconazole, afliconazole. Terbinafine, very important to know that terbinafine is contraindicated in liver disease, either chronic or active liver disease. So it's mandatory to do a first liver function test before initiating treatment, but there is no need for subsequent laboratory monitoring after treatment for immunocompetent patients. Then itraconazole. Itraconazole, we have two dosing regimen. We have the continuous and pulse dosing, interval treatment cycles, linear dosing, and usually for fingernails and toenails onychomycosis for both. Fluconazole 150 milligram weekly for at least 6 months of fingernails and toenails may be used if patient is unable to tolerate terbinafine or itraconazole. Then we come to the topical therapy. Topical therapy is less effective and more expensive than oral therapy. It can be used in case the first line treatment, which is the oral therapy, cannot be used because of the either contraindication or the patient compliance or many things, or also if the disease is very early, you can try topical therapy. The recommended duration of topical therapy is 24 weeks for fingernails and 48 weeks of toenails. So this is the main difficulty of treating onychomycosis, the long period of treatment. We have different types of topical treatments. Also, we have in onychomycosis, because it's difficult to treat, we have also surgical therapy, nail trimming and debridement can be used with oral or topical antifungals to increase treatment effectiveness for severe infection or when medical therapy fails. Then wavelength infrared or fractional carbon dioxide laser therapy are FDA approved for temporary cosmetic improvement of nails based on low-level evidence. So it's still low level evidence, but approved because it helped maybe it's cosmetically, it's not because it helps in the treatment itself. Combining laser therapy with topical therapy increase overall treatment effectiveness. Treatment courses for onychomycosis are long, as we said, 3 to 6 months. Failure rate, so because of this and the problem with compliance, absorption, and many things, the relapses are very high, up to 50%. Then we have again returned back to our cases. A 4-year-old boy is brought by his mother with history of rash over the face and arms. The mother is upset as the rash is resolving only temporarily when using topical steroid creams. Examination reveals scaly, pruritic, erythematous lesions over the face and the flexor surfaces of both arms. So, please, what's your diagnosis and how you describe your rash? Eczema, yes. How you treat it? Topical steroids, excellent. Okay. Emollient, excellent. Excellent. So we'll talk now about dermatitis. We have different types: atopic dermatitis, contact dermatitis, seborrheic, and exfoliative dermatitis. Because of the time limitation, we'll talk mainly about atopic dermatitis and contact dermatitis, which are the commonly seen. Contact dermatitis can be irritant or allergic. I have this table, very nice table. It shows you that atopic dermatitis as endogenous and then contact dermatitis exogenous usually causes, and the how to diagnose maybe clinical, but for the allergic contact dermatitis, maybe you will go for patch testing. For the allergic contact dermatitis, usually the allergen is not necessarily with contact, it's by systematic, taking systematic exposure may produce diffuse rash on the surfaces. So there are many differences between the 3 types of dermatitis. We can return to it later. There is the American Academy of Dermatology diagnostic criteria for atopic dermatitis. So when you can diagnose atopic dermatitis in a patient, we have the essential features, then important features, then associated features. So what are the essential features? There is chronic or relapsing presentation, eczema, acute or subacute or chronic. There is pruritus, typical morphology, and age-specific patterns. When you see the age-specific pattern, you will see that facial neck extensors in infants usually, but the children usually, they have flexor lesions, not extensors. The infants more in extensors, the children more in flexors lesions, and and usually sparing the groin and axillary regions. What are the important features supporting the diagnosis? There is most likely atopy, either personal or family history, like asthma, like other allergies, allergic rhinitis, allergic conjunctivitis, and many others. Early age at onset, immunoglobulin E reactivity positive, and there is cirrhosis, which is dryness. What are the associated features suggestive of diagnostic but not specific? Atypical vascular response, like facial pallor, white demographism, keratosis pilaris, and others, ocular or periorbital changes, perifollicular accentuation, lichenification, and prurigo lesions. So how to manage dermatitis in general? The goals of treatment are, we should discuss with our patient what are the goals of treatment so that he will not have a higher expectation and he will know how to self-manage these problems. Because of treatment are resolved the current skin eruption, relieve symptoms, treat underlying epithelial dysfunction, and engage in a maintenance therapy. Use of oral antihistamine is not recommended to reduce pruritus because it's not effective. So steroid is the main treatment. Patient education is the cornerstone of our management. We should inform our patient to avoid non-exacerbating factors like non-irritants, regular skincare routine, use of moisturizers to protect against dry skin Once the skin is dry, then the eruptions will come. Using moisturizers reduce the roses, pruritus, erythema, fissuring, and lignification. So, what are the indications to specialist referral for patients with dermatitis? Usually, the treatment of atopic dermatitis or even contact dermatitis in the primary care, but in some cases, we should refer them to a dermatologist. In case the candidates for allergen-specific immunotherapy is not responding to normal therapy, consideration for systematic immunosuppressive therapy, poor disease control with appropriate first-line treatment, severe or recurrent skin infection, viral or bacterial, significant psychosocial problems due to atopic dermatitis, uncertain diagnosis, and controlled facial atopic dermatitis. I will check the chat. Oh, okay, frequency, okay, excellent. Then the other case, 18-year-old woman present with skin rash on the face for 1 year. She has no chronic medical problems and is not on any medication. What's the diagnosis? Acne, excellent. How to treat? How to select your treatment? Okay, we'll proceed. So acne, it's very common disease usually in young adults, and it has 4 interrelated processes present: sebum overproduction, abnormal shedding of follicular epithelium, follicular colonization by the bacteria, and inflammation. What are the causes? Usually excessive androgen hormones, especially in young adults, or heightened sebaceous gland sensitivity to normal levels. And there are higher level of sensitivity, genetic predisposition, certain foods, particularly those with high glycemic index, and skin milk seem to affect acne severity. Other factors like psychological stress, tobacco smoke, and damage unhealthy skin. And medication side effects like what medication side effect? Common one. Excellent. Morphology, beside treatment, steroids, excellent. So, acne typically occurs in the face, chest, or upper back. What types of lesions? We have non-inflammatory closed comedones, whiteheads, open comedones, which call it blackheads, and inflammatory papules, nodules, pustules, and cysts. Goals of therapy. Also, we should agree with our patient what are the goals of therapy: reduction in comedones and inflammatory lesions, improvement psychological symptoms, and avoidance of scarring. So early treatment is recommended. In treatment options of acne, we have 2 mainly categories. We have topical agents and oral agents. So we have topical benzoyl peroxide or salicylic acid, topical antibiotics, topical retinoids, and azelaic acid. Then the systemic antibiotic, isotretinoin, oleuroapatine, and combined oral contraceptives rarely used. Then acne severity classified as mild, moderate, or severe based on 2 things: extent of the problem and type of the lesion. The lesions, if it is blackheads or whiteheads, usually it's going with mild one, cyst and pustules going with severe. Then the extent, number of lesions, the more number, it means more severe. Selection of treatment option depend on acne severity and type of lesions. I feel this picture, it will help you to select the needed treatment more clear. So if it is comedonal, where first choice is topical retinoid, then we have another alternative. We don't have topical retinoid, you can use azelaic acid, salicylic acid, which is also benzoyl peroxide you can use. Then if it is mixed, papular plus pure, topical retinoid plus topical antimicrobial, topical antibiotics. Then we have alternatives, the topical retinoid antimicrobial agent or topical retinoid with azelaic acid. If it is mixed with papular and pustular, but it's more severe than the mild one, we can use oral antibiotic with topical retinoid and benzoyl peroxide. Then the alternative is oral antibiotic, topical retinoid plus or minus the same, يعني selecting one of them. If it is nodular, then also again we can use the same oral antibiotic topical retinoid plus this time benzyl peroxide. And if it is more severe, you can use reacodine or oral isotretinoin or oral antibiotic topical retinoid. So you will go with, you will see from mild, you start from mild to moderate, plus the type of lesions will help you to decide the treatment. What are the antibiotics for acne? As we said, we have topical and systemic antibiotic. We have topical maybe clindamycin or erythromycin available in the market to reduce the risk of resistance. Better to avoid use of topical antibiotic as monotherapy or maintenance therapy. As you we see here, that we see that once we started using topical antimicrobials, we used retinoid with it. And as maintenance therapy, we are using maybe topical retinoid plus or minus benzyl peroxide. So we are not using topical antibiotic alone, or oral, even oral antibiotic alone. Limiting the duration of therapy to 12 weeks, which is equivalent to 3 months. Then systemic antibiotic, we have doxycycline as first-line therapy. Then we have other options like tetracycline and azithromycin. Limit the duration of therapy to 12 weeks, except in selected reluctant cases. So isotretinoin, common dose dependent, very important to recognize the side effect of reacotine or isotretinoin, because many patients will come to you complaining of the side effect. So cirrhosis, skin dryness, cheilitis, which is skin mouth dryness, acne flare-up, especially at the beginning of the treatment, dry eyes, headache, elevated lipid, and hepatic enzymes. Patient receiving isotretinoin should be counseled about associated risk, which is LFT and lipid panels monitoring until stability is assured. So before treatment, you should check LFT and lipid profile, and then after treatment, also rechecking until you reach stability, then maybe you can stop. Usually, this medication started by dermatologists, but we are seeing this patient because they come with their complaints like side effect or other questions. All female patients must have pre-treatment, post-treatment, contraceptive counseling, and monthly urine pregnancy test because of the residency of the medication, and at least 2 to 3 months stopping the medication before getting pregnant. What do we have other modalities? We have physical modalities like laser, light-based modalities, chemical peels, comedo extraction, but all of these still lacking high-quality evidence. And we have complementary therapy like dietary intervention, low glycemic load, diets, and avoidance of diarrhea. So, as we said, the food-related causes. So, and plus acupuncture, cupping, herbal medicine, and all of these, there is no high quality evidence. Okay. We have this patient, a 50-year-old woman, present with skin rash on the face for 1 year. She has no chronic medical problems and is not on any medication. What's your diagnosis? Rosacea. Excellent. Okay, how to treat rosacea? Rosacea is the acne of the elderly, or maybe you can say this. Rosacea is a chronic facial skin condition of unknown cause. The rash characteristics are involvement of central face, transient or persistent erythema with a feeling of warmth. So it's associated like with a feeling of warmth in the face, a feeling of hotness in the face, telangiectasia, inflammatory papules and pustules, hyperplasia of connective tissue. How to manage? It's non-pharmacological, and I didn't particularly chat, azelaic acid, promethazine topical, ivermectin, okay, local metronidazole, okay. So the treatment, you can divide it to non-pharmacological and pharmacological. Non-pharmacological avoidance of triggers, use of mild cleansing agents, moisturization of the body and the face, especially photoprotection with wide brimmed hats, and broad spectrum sunscreens. What are the pharmacological? As you said, topical metronidazole or azelaic acid for inflammatory lesions and erythema. Topical bromelain as effective in reducing the erythema. Papulopustular rosacea systematic mucostar systematic antibiotic. Pigmentus rosacea laser or light-based therapies, and ocular rosacea is managed with lid hygiene, topical cyclosporin, and topical systematic antibiotic. Now, this is a 30-year-old man present with a skin rash on both forearms for 3 months. The rash is itchy and he has no chronic medical problems and it's not in any medication, and commonly we are seeing in primary care. Excellent. I see the answers. Excellent. Psoriasis. Okay. How to treat psoriasis? Usually mild forms, yes. I think, okay, excellent. Because psoriasis is mainly a mild psoriasis, you can treat it in primary care. So psoriasis is an immune-mediated process triggered by interplay of genetic, environmental, physical, and infectious causes. It can be associated with cardiovascular disease, obesity, metabolic syndrome, diabetes mellitus, and inflammatory bowel disease. It has different forms: plague, luteate, erythrodermic, pustular, inverse, and nail psoriatic arthritis. All of these are different types and forms of psoriasis, can come together or differently. 90% of psoriasis is a plague psoriasis. It's diagnosed clinically, usually based on the presence of characteristic erythematous scaly skin plaques in typical locations, with associated history and systemic symptoms. How to treat? Also, we have non-pharmacological and pharmacological. Okay, check the chat. Okay. Non-pharmacological, maintaining ideal body weight because it's related to obesity and other diseases, avoiding tobacco products, limit alcohol intake, practicing stress reduction technique because it's with the stress, it flare up more. The psoriasis area and severity index is a tool to assess severity and monitor treatment effectiveness over time. So pharmacological, what we are using, as you said, topical steroids, vitamin D analogs, and tazarotene as used to treat mild to moderate disease. Systemic treatment with non-biologic, unbiologic agents and ultraviolet phototherapy are used for moderate to severe disease, usually in dermatological clinics. So this is, I thought this algorithm will help you to decide what type of treatment you will go for your patient. You will divide the patient mild, moderate, or severe by the percentage of involvement and severity of the disease, and then you'll decide the treatment. So determination of the disease severity by assessing the PSA involvement or PSA score. Consider impact of disease on physical, psychosocial, and social well-being with DLQ1, or if younger than 16 years, CDLQ1. Evaluate for psoriatic arthritis if present the disease is considered severe. So only one slide I wrote it for skin malignancies. The important thing in skin malignancies is the urgent referral and early detection of the alarming symptoms when the patient present. What are the alarming symptoms? If there is odd or ugly duckling mole, if there is change in the appearance, size, or shape or color of the mole, change in symptoms like itchy, painful, or bleeding, changing lesion, asymmetry, irregular borders, pigmented multiple colors which may extend beyond the border, larger or if it is larger than 6 millimeters. So if any of these symptoms present or signs, urgent referral for dermatological care. Okay. 60-year, I think this is the last one. 60-year-old man present with history of burning sensation in the right side of the back for the last 2 days. He is known case of type 2 diabetes on medication. He has no fever, examination reduced the following. describe the rash. Okay, exchange. Oh, sorry, I didn't open. Herpes zoster, excellent. Fingers, yes. Physical area. How to treat it? Okay. Acyclovir, antiviral, excellent. Excellent. Nothing. So, herpes zoster, or we call it shingles, is caused by reactivation Bacillus zoster vaccine, a virus, sorry, or chickenpox, present as painful blistering. Usually, herpes zoster is 20 to 100 times more common with older age, or when the cell-mediated immunity wanes, or with a immunocompromised patient. So the major risk factors for herpes zoster is the age. How it presents usually affects a single unilateral dermatome. So it follows the dermatomal distribution. 2 to 3 days before the rash, patient may present with malaise, headache, low-grade fever, and abnormal skin sensation. The classic maculopapular lesions appear approximately to distal, so it will start from proximal area to the distal one. For example, if it is in the back, we start from closer to the spine, then it will go spread more distally. Progression to clear vesicles over 3 to 5 days, so the vesicles will stay 3 to 5 days, then become cloudy, eventually crust over 7 to 10 days. Lesions usually heal 2 to 4 weeks after the onset. Diagnosis, mainly it's clinical diagnosis. So, how to treat shingles? The pharmacological use of antiviral medication, glucocorticoid, doesn't reduce incidence. This is very important post-herpetic neuralgia. We are treating patient, but treatment doesn't reduce the incidence of post-herpetic neuralgia, which is the common complication of herpes zoster. About 30% of patients develop post-herpetic neuralgia. So the pain management, we'll start with pain management. Treatment of acute pain depends on its severity and impact. If it is only mild to moderate pain, may be controlled with paracetamol or non-steroidal. And if it is severe cases, may require opioids. Anticonvulsant, tricyclic antidepressant, or nerve block may be considered for patients with suboptimal pain control. So we start with non-steroidal and paracetamol, then opioids, but then if they are still not controlled, we can go for like pregabalin, amtriptyline, or others. What are the oral antivirals? First of all, what is the aim of starting oral antiviral? To decrease the time during which new lesions occur by 12 hours. So reducing the number or progression of the vesicles, and decrease the time to full crusting by 2 days, and decrease pain severity. What are the options? We have acyclovir, valacyclovir, and famciclovir. Acyclovir is the one is FDA approved, but the problem with acyclovir that it's taken 5 times a day, so it's the compliance is a problem. But it's very important to know that the oral antiviral should be started within 72 hours of development of the rash. So if the patient came after the window period, no need to start because there is no much of benefit. If new skin lesions are still developing, you can also, even beyond 72 hours, you can give oral antivirals. And there is if ophthalmic or neurological complications present also, if it is beyond the 72 hours, you can give oral antivirals. What is the role of glucocorticoids in this patient? It's adjunct to antiviral therapy. They reduce acute pain and promote early healing, but glucocorticoids shouldn't be used alone without oral antivirals. What are the complications? We have herpes zoster may be associated with many complications, the pain itself, post-herpetic neuralgia, as we said, and visual complications, especially if there is ophthalmic involvement, neurologic complication, and visual complication. I have this picture almost summarize all of the complications. We'll talk briefly about post-herpetic neuralgia, which is the most important complication. It is pain in dermatomal distribution sustained for at least 90 days after active herpes zoster. Treatment options is only symptom control. You can use topical lidocaine, caption, oral gabapentin and pregabalin or tricyclic antidepressants. How to prevent herpes zoster? We can prevent herpes zoster by two things. First, the vaccination. It decreases incidence of herpes zoster. So, the vaccine is approved for adults 50 years and above, but the recommendation only for 60 years and older. But only used specialized attenuated vaccine only used for immunocompetent patients. What advices we should give our patient? Avoid close contact with people until the blisters have healed, especially pregnant lady, because may cause teratogenicity to the baby. I check the chat. Okay, excellent. This is treatment. What are the doses? The dose acyclovir is written 805 times a day. Balcyclovir, I think it is 500 TID. I'm not sure. Maybe we need to check it. I'm not sure about it. Okay, this is all, and thank you very much. Any questions?
يعطيك العافية دكتورة. Excellent lecture, ما شاء الله.
We can use cryotherapy for facial lesions, but only if it is, as we said, if it is cosmetic and very important to do. Okay.
Doctor, they're asking about the dyslipidemia with the acne medications.
Dyslipidemia with acne, you mean the Accutane, you mean treatment? Yes. Or what?
Yes.
Okay, in case there is derangement of the lipid, they should stop the medication. Or it's dose dependent. Sometimes they will start with the small dose, I think 50 milligram. If it is, but because of partial response, they will increase it to the higher dose. Then if dyslipidemia happened, maybe they can reduce the dose.
What is the difference between bolus and the bolus Impetigo?
Okay, the difference with the looking, the bullous one is more bullous-like, but the non-bullous it's less like. يعني bullous is less, size is less. Waiting, is it most likely fungal cause? Most likely, yes, because fungus like humidity in general يعني. Not all types طبعا, but ممكن candidiasis, tinea cruris, tinea pedis, all of them related to humidity. What is the treatment of melasma? Okay, melasma is a hyperpigmentation. They are using hydroquinone, and usually we are referring to dermatologists in cases of melasma, but they are using they can mix retinoid اللي هو topical plus hydroquinone. And طبعا avoidance of exposure to sun and stress control. Get contact with someone with shingles. What is the treatment should receive? Okay. If it gets contact with the shingles, it means that we treat her like chickenpox. We check the immunoglobulins. If there is immunoglobulins, it's okay. If not, we start her with prophylactic treatment. يعطيها immunoglobulins. One minute, other questions, not a lot. What is the difference between bullous? Okay, in case of pregnant. خلاص, I think I answered all the questions. Am I right?
Yes. ما شاء الله دكتورة, excellent lecture. يعني you covered everything. والinteraction with the participant كان عجيب.
Thank you very much. I like it.
دكتورة.
Okay. Thank you very much.
Thank you دكتورة أسماء.
Thank you.
Good
learning. Okay, إن شاء الله.
يعطيك العافية.
بارك الله فيك. مع السلامة.
Thank you everyone for attending our first day for this review course. Just a kindly reminder, first of all, please make sure that you write your names so we can check the attendance. I've seen some names here says anonymous attendee. So make sure that you sign up with your name so we can make sure to count the attendance. Second of all, we're starting tomorrow, inshallah, at 9 a.m. sharp. So bring your coffees, be ready, and best of luck. Thank you, everyone, and have a nice weekend.
Can I end the webinar?
Yes, please.
Thank you.